Good morning, ladies and gentlemen. First of all, I would like to thank the organizer of UiTM First International Online Vestibular Conference for inviting me to give a talk on vestibular neuritis. I am Dr. Nor Azmi Mohamad, an otorhinolaryngologist currently practicing in a private medical center. Vestibular neuritis, also called vestibular neuronitis. The term vestibular neuronitis was first coined in 1952 by Dix and Holpikes. They describe a clinical entity characterized by vertigo with the absence of cochlear signs and symptoms. Now we describe vestibular neuritis as a condition characterized by acute prolonged spontaneous vertigo due to unilateral peripheral vestibular hyperfunctions. It is the most common cause of acute prolonged spontaneous vertigo, which account for up to 9% of the patient visiting a dizziness clinic. It has incidence of 3.5 per 100,000 population. Vestibular neuritis is in fact the second most common cause of peripheral vestibular vertigo. The first one would be benign paroxysmal positional vertigo. The name vestibular neuritis suggests an inflammatory process of vestibular nerve. So, what causes these inflammations? Currently, there are mounting evidence that this inflammation is caused by reactivation of latent type 1 herpes simplex virus. The possibility is supported by detection of this virus in about 2/3 of human vestibular ganglia on autopsy. In animal study, vestibular impairment can be induced by infecting vestibular ganglion cells with HSV. Another mechanism that might cause this inflammatory process is autoimmunity and microvascular ischemia of the vestibular labyrinth. Although patients may report preceding or concurrent viral illness, the evidence to support systemic viral infection is lacking. Diagnosis of vestibular neuritis is a diagnosis of exclusion, which are based on both the bedside and laboratory evaluations. So this diagnosis is based on the key symptoms and signs, which includes number 1, acute prolonged vestibular symptoms such as vertigo, nausea and vomiting, and unsteadiness. Number 2, the presence of unidirectional, horizontal, torsional nystagmus beating away from the site of lesions. And number 3, impaired semicircular canal functions, which can be documented with heat impulse test or caloric test. Heat impulse test and vestibular evoked myogenic potential make it possible to evaluate all the 3 semicircular canals, the otolithid organs, and this has enabled us to define another subtypes of vestibular neuritis, whether it is total, superior, or inferior. This video demonstrates right beating nystagmus, which obeys Alexander's law. We can see when she gazes to the left, the nystagmus is suppressed. But when she gazes to the right, the nystagmus amplitude increase. Now we know that vestibular neuritis can be complete, superior only, or vestibular only. What are the clinical features of complete vestibular neuritis? It is characterized by subacute or acute onset of spontaneous vertigo with nausea or vomiting, the presence of illusory sensation of spinning of surrounding in the direction of nystagmus squid face. When a patient closes their eyes, sometimes they can tell which way they are spinning. And if we look at the nystagmus, the way that they are spinning is into the direction of nystagmus quick phase. And examination of the eyes shows that horizontal with a bit of torsional spontaneous nystagmus beating towards the unaffected side. And as I mentioned earlier, the nystagmus follows Alexander's law, and it is partially or totally suppressed under visual fixation. Head impulse tests or caloric testing can demonstrate the impact functions of this semicircular canal. Another important clinical features of complete vestibular neuritis is oculative reaction. This oculative reaction comprises of three things: head tilt, skew deviation of the eye, which is one eye sits lower than the other, and ocular torsion, which can be seen on fundoscopy. In a complete vestibular neuritis, this oculative reaction is ipsiversive. That means it is tilted towards the affected sides. The full picture of the oculative reaction, however, is not very often seen clinically. And in fact, the absence of skew deviation of the eye makes us able to differentiate between a peripheral and a central disorder. Skew deviation tends to persist in a brainstem lesion compared to transient in a peripheral lesion. There will be also decreased or absent response of vestibular evoked myogenic potential during stimulation of the affected ears. This response might be normal or abnormal depending on the subtype of the vestibular neuritis. Convex tests tend to be positive, falling towards the site of lesion, and in Fukuda stepping tests, the rotation is ipsiversive. Superior vestibular nerve supplies utricle, anterior canal or superior canal, and horizontal canal or lateral canal, whereas inferior nerve supplies the saccule and posterior canal. By testing each of these organs, we can deduce which nerves are affected by these conditions, whether it is superior, inferior, or both. In literature, there are reported slightly more than half of the cases of vestibular neuritis are total or complete. 40% were superior vestibular nerve, and the rarest one is the inferior vestibular nerve. Involvement of superior vestibular nerve can be demonstrated by abnormal ocular vamp and superior horizontal canal V-hit impairment, whereas in inferior vestibular nerve involvement, there will be abnormal cervical vamp and posterior canal V-hit impairment. This table shows different pictures in different type of vestibular neuritis. In a complete vestibular neuritis, the spontaneous nystagmus will be horizontal torsional, beating away from the site of lesion, whereas in superior vestibular neuritis, the spontaneous nystagmus will be horizontal, torsional, and upbeat, and also beating away from the lesions. And in inferior vestibular neuritis, the spontaneous nystagmus will be torsional and a bit of downbeat. So the presence of torsional downbeat nystagmus might not necessarily means a central lesions. It might also means inferior vestibular neuritis. If you have V-hit, you can test each of the canals separately. It is worth noting that caloric tests will be normal in inferior vestibular neuritis. Other tests like subjective visual vertical, OVAM and CVAM can be done, but whether it is necessary, it is debatable. This is a complete oculative reaction. There is head tilt to the lower eye. Skew deviation means that one eye sits lower than the other, and ocular torsion to the lower eye, which can be seen on fundoscopy. It is estimated that about a quarter of acute vestibular syndrome that presents to emergency department are actually due to stroke. So how do we differentiate this acute vestibular syndrome, whether it is stroke or is it a peripheral vestibular disorder? The most effective way to rule out a life-threatening disorder, which is central disorder, is to rule in one of the peripheral vestibular disorder. So people has devised this bedside examination called HINS, which includes head impulse test, the presence of nystagmus, and test of skew. Peripheral vestibulopathy can be diagnosed with a high level of certainty in the presence of unidirectional nystagmus, a positive head thrust test in the direction opposite to that of the fast phase of nystagmus, and the absence of vertical eye misalignment or the absence of skew deviation, and of course no other neurological features. So what are the laboratory tests that can be done in patient with vestibular neuritis? All these VHITs, caloric testing, VAMS, SVV was discussed yesterday, so I'm not gonna touch about it today. MRI is used to rule out central vestibular disorder, or if you suspect there is central vestibular disorder, whether it's stroke or whether it is an vestibular schwannoma, they suddenly bleed. So it depends on your clinical evaluation as well. Of course, audiometry is also essential to exclude any audiological sign. This is a VHIT machine by Synapses. So this camera here can detect head movement and the eye movement, and there will be a computer that analyze this head movement and eye movement, and it compare its velocity. This is how an analysis of VHIT will look like. In a healthy subject, you can see here the head velocity, which is in yellow, and eye velocity in blue will be almost the same. So they can say the gain is about 1. However, in unilateral vestibular loss, the head velocity and eye velocity is not the same. This is what we see clinically as a corrective saccades. So the gain will be markedly reduced in a unilateral vestibular loss. What are the differential diagnoses of vestibular neuritis? This can be a central lesions mimicking vestibular neuritis, or it is a peripheral lesions that mimic vestibular neuritis. Central lesions can be infarction in the pontomedullary junction, cerebellar infarctions, and even vestibular migraine. In peripheral lesions, sometimes vestibular schwannomas can present with acute vestibular syndrome. Meniere's disease initial presentations might also present with just vertigo without an audiological symptoms. Natural spontaneous cause of vestibular neuritis: after this onset of acute vertigo, patient will feel severely ill and prefer immobilized in bed for 1 to 3 days. During this time, they avoid head movements, which can exaggerate the symptoms until vertigo, postural imbalance, and nausea subsides. This will happen in about 1 to 3 days. After day 5 to 7, the spontaneous nystagmus is largely suppressed by fixation in the primary position, but depending on the severity of the canal palsy, it may be present for up to 3 weeks with Fresnel glasses or on lateral gaze directed away from the lesions, or sometimes it can be induced by head shake. In about 1 to 6 weeks, most patients will feel symptom-free. The actual recovery, however, depends on whether and how quickly central compensation occurs and possibly on how much physical exercise the patient has done. In those who do not regain normal labyrinthine function, rapid eye movement, however, may still cause slight oscillopsia and impact balance for a second. Interestingly, the spontaneous nystagmus may transiently reverses its directions when central compensation occurs. What about recurrence rate? In one of longest long-term follow-up study, up to 20 years with mean follow-up of 9.8 years in a total of 103 patients with vestibular neuritis, only 2 patients, or 1.9%, developed a second vestibular neuritis. In both cases, it affected the contralateral ear and they caused less severe distressing vertigo and postural imbalance. Now, we come to the treatment of vestibular neuritis. We can categorize this treatment into symptomatic treatment, causal treatment, and physical rehabilitations. For symptomatic treatment, in the first 3 days, vestibular sedative are usually very effective in relieving the symptoms of vertigo, nausea, and vomiting. However, their major side effect is general sedations. And also, this drug should not be given for longer than 3 days because they may prolong the time required to achieve central compensations. I have seen many patients come with chronic vertigo because they've been on this vestibular sedative for too long. Based on the understanding that vestibular neuritis is caused by latent HSV1 infections and inflammation, it is logical that the early administration of steroid monotherapy may improve the rate and extent of recovery of vestibular functions. Although the evidence are weak, it is generally agreed that if steroid is given within 72 hours after the onset of symptoms, it may hasten the recovery. Some may give it up to 3 weeks and they tail it down. However, recent studies indicate that although it improves a short-term outcome, it does not improve a long-term outcome. Antiviral had no influence on the disease course, whether as a monotherapy or in combination with methylprednisolone. This study shows caloric response at follow-up after 3 months for treatment within 24 hours versus after 24 hours. So, those who were given steroid within the first 24 hours of onset are doing much better compared to those who were given later. The third component for treatment of vestibular neuritis is vestibular rehabilitations. The most important principle of therapy is to promote central compensation by means of physical therapy. Central compensation is not a uniform process. It involves various neural and structural mechanisms that operates in the different locations, vestibulospinal or vestibulo-ocular areas. This exercise first recommended by Cawthon in 1944 and later modified accordingly to new knowledge of the vestibular functions. In general, they include gaze stabilization exercise to recalibrate the vestibulo-ocular reflex, balance training, goal-directed movement, gait exercise to improve the vestibulospinal regulation of posture, and goal-directed motions. In about 10 to 15% of patients, with vestibular neuritis, they do develop BPPV in the affected ear within a few weeks. However, BPPV is easily diagnosed and easily treated and shouldn't be confused with incomplete recovery. However, some patients do develop into chronic vertigo. They develop persistent postural perceptual dizziness. This is important because this consists of huge chunk of patients in vestibular clinic. So who are these people who develop into chronic vertigo? It is thought that those with visual dependence, that is, rely too much on visual stimulus for their balance, those with anxiety, and those with somatization traits, those with extreme concern about their symptoms. These patients will develop into chronic dizziness. Now I have come to the end of my presentations. There are a few take-home messages. Number one, vestibular neuritis is an inflammatory disorder, possibly of viral origins. Clinical diagnosis with hints is very useful bedside test to rule out central disorder, and you can diagnose type of vestibular neuritis with the use of head impulse test, and vestibular rehabilitation is the most important part of therapy for vestibular neuritis. With that, I thank you.